Well, it's really great to meet with you, Dr. Madden. You are a very big part of upper tract disease. You have been a part of a lot of the research, and it's great to hear from you about certain topics. The first topic we're going to talk about is lymph node dissection, and then we'll talk about kidney sparing management and some of the latest that have been added to the guidelines this year. Just jumping into lymph node dissections, can you give us a little bit of background on the data that supports the use of a lymph node the performing a lymph node dissection at time of surgery?
Well, I think from a general disease perspective, we have data from bladder cancer, and we do know that for urothelial disease, lymphadenectomy plays not just the staging role, but a potentially therapeutic role. So we have that with bladder. And of course, a lot of what we do in upper tract, we extend the knowledge to upper tract. The difficulty, I think, for many people has been, which lymph nodes,
Right.
which is an absolutely important question. And so the data that we have in that regard, really the Japanese were the first to be able to systematically look at this. And Dr. Kondo in Japan has been one of those people that has been working on this since the early 2000s. And so they did an initial mapping study. And then one other thing that I have to give credit to them for is not only did they do the mapping study, but then they basically defined what they thought was an adequate template and what was an inadequate template. And then moving forward, they evaluated their data based on those standards. And so subsequently, what they did, they created a registry. And it's kind of a prospective study, but not really. But they did prospectively prescribe what their lymph node templates would be, for proximal ureter and renal pelvis tumors. And with that data, they were actually able to show that there was a therapeutic benefit, particularly those patients who had more locally advanced disease. When they looked at pathology for those with T3 disease, and if they had what they defined as an adequate lymphadenectomy, those patients did better than those who did not have lymphadenectomy. And this is consistent with what we would expect with with bladder data as well.
Sure.
That there's microscopic lymph node disease that is not detectable by imaging. And that in some of those patients, they do well, they do better with removal of those lymph nodes. We followed up on that data with a multi-institutional study where we did the mapping study. And this was all with either biopsy-proven nodes or pathologically proven lymph nodes. And we corroborated the Japanese data, but also with a smaller number of patients who had mid and distal ureter tumors. What we're starting to glimpse is that those patients actually appear to have cranial migration of metastases. So even though, like for a patient with a distal ureter tumor, you would think you should just do a pelvic node dissection, what we're finding is that a lot of patients actually will metastasize to the upper retroperitoneum, not quite up to the hilum. But for example, for a left-sided distal ureter tumor, you may see mets in the lower para-aortic area. And we have certainly seen this multiple times over and over again. And it may explain why the data for lymphadenectomy for the lower ureter tumors isn't as strong, because we're just not removing the correct lymph nodes, quite possibly in
Right.
many of those cases.
Sure.
Yeah.
Is there a difference between low risk and high risk patients?
Yeah, for sure. I mean, the data doesn't suggest that there's any benefit for lymph node dissection in lower risk patients. And really the benefit is for the locally advanced disease, where of course the risk of micrometastatic disease is higher. Now, the difficulty we get to with that is that we're not very good at identifying low risk necessarily. So, sometimes we're doing a case and the fellow's like, well, why are you doing a node dissection? It's low grade. And I said, yes, we think it's low grade. It may be very multifocal or high volume disease. And I know I got just a tiny snippet of a biopsies that says it's low grade. But I am, concerned that there's some risk for upgrading and upstaging. And so in those cases, even though it's potentially low risk, I may do some level of lymph node dissection. Therapeutically, I don't know, but I know for staging, it would help them. especially then if they get upgraded or upstaged, I'll feel better about having that, having done that and spent an extra 15, 20 minutes.
Absolutely. Great. And what you mentioned a little bit, but what are those risk factors? What or what are cluing you in that maybe there needs to be a lymph node dissection for this patient? What are some things you're looking at?
So great question. It's a moving target. You could very easily, to keep it in a very simple binary world, go by grade, low grade, high grade, and do it in high grade disease, which isn't unreasonable. But as we know, there's plenty of high grade disease that's not very high risk. And with the new guidelines, we did try to get a little bit more granular with that, where we talk about favorable and sort of unfavorable high risk classification, for example. What I do in my own practice, I use clinical nomograms. There's 3 of them that I find to be pretty reliable, but not a single one is, there's not a single one that's absolutely perfect. So as laborious as it is, for just about every case, I look at all 3 nomograms.
Wow.
If all 3 of them are pointing in the same direction, then I'm very confident about what we're looking at. If there's 2 out of 3 that are pointing in the right direction, then I'm, have pretty good confidence, but I know that they may be off. If all 3 are all over the map, then of course, actually that doesn't happen very often. I don't think, at least 2 of the nomograms generally point in the same direction.
Sure.
And of course, they're all from slightly different populations. So, and that's the case with any nomogram. So I use the nomograms as a guide, and I either don't do a node dissection, or I do a very sort of a more limited one. If it's sort of more favorable high risk disease, and then I might do a more an extensive one if it's really high risk disease, or patients who are getting neoadjuvant chemo because we were really worried. In those cases, I'll do a more extensive node dissection. So I have basically like 3 buckets of gradations of dissection that I'll do.